in whoops, we have a little, there we go. Little technical glitches on the back end. When we go live on YouTube, YouTube pops up on my screen, and then my medical notepad jumps up and starts talking to us. And so we're hearing a lot of noise as we're trying to get started with the live stream this morning. Good morning, everyone, live from the new Cardiovascular Horizons conference in New Orleans, Louisiana. I am with world-renowned interventional cardiologist, my opinion, Dr. Eric Dippel. And yesterday when we were live, you might have heard him up on the podium. I'm not sure that you stepped foot off the podium most of yesterday.
Yeah, I was up there for a while, so yeah. Well, I appreciate the gracious introduction. I don't know if I'd be quite deserving of that, but thank you.
He's amazing. He's one of those doctors that literally will go to bat for patients. And if everyone recalls that big New York Times article that came out, and it really put a damper on things for people with the most advanced stage of peripheral artery disease, which is critical limb ischemia or CLI, he went to bat. He was literally, I think, the main one that stood up for your right to have the right treatment for you and to make sure that you weren't going to fall through the cracks throughout this process. So from all of us, we really appreciate all you have done to really advocate for patients over the past year.
Thank you.
It's been really, really amazing to watch. So we got a lot of questions for you that were coming in.
Let's do it.
I am thinking that we might want to start with some folks in the group that might have questions up here that joined our live studio audience. Darlene or Tammy or Douglas, any questions before we get started on the list that I've collected over time? Darlene, go ahead.
Yes, thank you, doctor. I was diagnosed with atherosclerosis. I don't have the typical risk factors. I don't smoke. I don't have diabetes. The doctor thinks it's genetic. And it's just in my legs. My heart checked out fine. I had angioplasties in both legs last fall. It's plaque. There's no calcium. I don't have resting pain or wounds. So I have been, the blockages have returned in my thighs. So 3 months later, the blockages where they opened them up returned. And so I've been building up collaterals and walking 2 miles a day. And I'm feeling pretty good. Yeah, I'm feeling pretty good. So I have two questions because my doctor says she has no one like me in her practice. Like I'm kind of a conundrum. So for a patient like me, is a blood thinner for the rest of my life necessary? And number two, if I can maintain this lifestyle by not intervening for 2 or 5 or 10 years, is it going to make it harder to intervene on me in the future?
Yeah, those are great questions. And I think the easiest way to answer that would be to kind of start from the beginning and explain what the disease process is rather than jumping in the middle of the river, so to speak. Arteries in the body get clogged up over time, the way the plumbing in your house gets clogged up. And that's the simplest analogy I can use. And you may not do anything wrong. That just may be partly how your genes are put together, and that stuff is going to happen. And so it doesn't mean you're a bad person. It doesn't mean that you smoked. It doesn't mean that you have diabetes or anything, but it's kind of part of the aging process, the same way we get joints that ache and, our hair turns gray and falls out and all those other things. It's kind of part of the aging process, right? So there's really only 2 reasons to treat people as far as interventions go. One is to make you feel better, and 2 is to make you live longer. And so if we can't make you feel better, we can't make you live longer, it's not really worth doing an intervention every other day to try and keep an artery open per se. Now, if you're having a lot of symptoms, that's a reason to try and fix things. But having said that, no matter what procedure or intervention you have, whether it's a balloon or stent or bypass or whatnot, those are only plumbing tools. The same way as if I come and unclog your kitchen sink in your house, it doesn't mean it's not going to clog up tomorrow or 5 years from now. And so the medications that you end up being on to keep your cholesterol super low or to keep your blood a little bit thin, those are extremely important to keep your blood pressure, adequately low. And if you have diabetes or anything like that, those are the underlying problems that cause this. And so treating those with medications for the rest of your life is extremely important because you're not going to die because your leg hurts. You're going to die from a heart attack or a stroke down the road. I mean, that's the reality of it. 40% of the United States population dies from heart disease. And so even if I fix your leg today, that doesn't mean you're not going to have a heart attack tomorrow. And so the medications, the blood thinners, the cholesterol medicine, the blood pressure, the diabetes, all that stuff is extremely, extremely important to treat the underlying disease process. You know, PAD is not like taking out your appendix. It's not like a one and done. It's not like you're cured, or take out your gallbladder and it's over. It's a disease process. Just like high blood pressure is a disease process. We can control it with medications, but you're not really ever cured of it per se. So even if I open up your artery today, you're still not cured of the disease process to put that there in the first place, if that makes sense. So
Yes, yeah, thank you.
So having your arteries blocked is not the end of the world. It's really the symptoms that they cause. And then whether you're having symptoms or not, and you know, if you're in a limb threatening situation where you have such critical reduction in blood flow that your leg is having a problem, that's a different issue. But if you're able to walk 2 miles a day and you feel good, I absolutely would not do an intervention on you, but I would highly recommend that you continue all your medications forever to prevent you from having more problems down the road. I hope that answered your question.
That does. Thank you. And just to be clear, if my ABIs continue and my toe blood pressures continue to be above what's considered severe, and I can continue to walk, if I could do this for 5 years, 10 years, that's okay to have a plugged up thigh?
I haven't had hair for 20, 30 years and I still get around every day. Okay. So it's your body adapts to things, and your body will adapt to the blockages, and you'll develop collateral flow and stuff. And so it's not a problem. And if you can live the rest of your life like you are right now, I wouldn't get overly worried about it. Okay. Just keep doing the right thing. If down the road, if you start feeling like you're having symptoms, then you can address it. I'm not saying that you may not need another procedure at some point down the road, but I'm saying if you feel fine and you're able to do your normal daily activities, then that's really what really matters. I have patients that their biggest activity of the day is walking from the couch to the refrigerator, and I have some patients that want to run marathons. So it's really what your lifestyle is and what you want to accomplish during the day. And if you can do that, then I wouldn't worry about whether you need a procedure or not.
And I think that, you know, one of the questions I get asked all the time, isn't it easier for a doctor, or doesn't it make sense for a doctor to treat, let's say, and I'm going to use more clinical terminology than they do, but a short focal lesion versus waiting, and then what are the chances of it growing into a long calcified occlusion that becomes the Achilles heel, like in the SFA?
Yeah, that's more a process of that's more a factor of the disease process per se. And so I wouldn't dwell on the technicalities of that kind of stuff. I mean, those are more things that doctors would worry about. I mean, if you have a 1 inch occlusion, or if you have a 10-inch occlusion, I wouldn't focus on that number. That's what the doctor worries about when they try and fix it. But I wouldn't lose sleep over whether you have a 1-inch blockage or a 10-inch blockage. That really is irrelevant to you.
I love this because he's an advanced skilled doctor, and literally he treats the most complex occlusions, complex blockages. So it doesn't even faze him. It doesn't matter. I don't care whether it's short or long or whatever. I'll get in there and I'll just do it. Yeah. I'll just get her done.
Yeah.
Oh, that's fantastic. Yeah. That gives me a lot of reassurance, because on my left thigh, it is, you know, it's
yeah. I mean, people get focused on things that are not relevant to their own care. So I wouldn't worry if it's like I said, whether it's a 1-inch blockage or a 10-inch blockage. You know, I mean, if it's the entirety of your leg and you have no blood flow in your entire leg, that's a whole nother issue. If you got a blockage that's 4 or 5 feet long, that's a whole different argument. Yeah, but if you're just worried about a segmental blockage, I wouldn't get too excited about that.
But we always suggest, Darlene, that it's always good to get a second opinion. Make sure that you do have a couple people in your back pocket so that you can always weigh if something needs.
Yeah, I've got 2 doctors. Thank you. Yeah, thank you so much. I appreciate it.
That is perfect. Something interesting also that she mentioned was that she has plaque, but not atherosclerosis, but atherosclerosis is plaque.
Yeah,
But there are different types of plaque that you might have in there.
it's really kind of semantics. I mean, I call it grunge. It's the same stuff, the grout that's in your shower, it's the gunk that's in your kitchen sink, it's a combination of cholesterol, inflammatory cells, fibrosis, calcium, blood clot. When you look at this stuff under a microscope, it's not one pure compound. It's a heterogeneous mix of gunk. That's what I call it. And so plaque and atherosclerosis, hardening of the arteries, all those are just synonyms. They're all similar terms that all mean basically the same thing. So, it's like I said, in layman's terms, the simplest way to think about it is your pipes are getting clogged up. What you want to label that as is how it's blocked up, but usually what happens is you have some cholesterol or plaque that builds up, and then it gets kind of to a critical point, and then you get a little blood clot in there, and that's what clogs up the artery acutely.
Yeah, and one of the things I hear a lot is I have normal cholesterol, but it's not until when I hear people say they have normal cholesterol, I always say, have you had an advanced lipid panel and get the particle number? Because you can have a lot of large, fluffy LDL particles, or the so-called bad cholesterol, and be fine, but it's the balance, it's the quality that you need to worry about, because you can have a lot of small, dense LDL particles, and those are the ones that can eke into damaged areas of the walls and cause trouble for you.
I think that is a really, really great question, and it's a big misconception, because there really is no normal cholesterol. There's no such thing, in my opinion, as a normal cholesterol. Cholesterol is a linear relationship to the amount of plaque that is deposited in your arteries. And so if your cholesterol is very, very high, you're going to have a lot of plaque. If it's very, very low, you're going to have little plaque. And there's no magic cut point that says if your cholesterol is over X or under Y, that you're going to be magically safe. So the bottom line is, the lower the bad cholesterol, the better. And so you don't have any symptoms with cholesterol. You don't feel sick. You don't have a toothache. You don't have a headache because your cholesterol is high. And so most people say, oh, my cholesterol is good. I say, well, what's your cholesterol number? They can't answer it. My doctor said it was good. Well, what does that mean? They don't know. So I believe that everybody, if you've ever eaten at McDonald's, you need to be on a cholesterol medicine. It's that simple.
It's interesting because I know a lot of cardiologists that actually take cholesterol medicine.
I have for 20 years. Who's going to put my stent in?
I think you have a lot of friends here that you would trust.
Yeah, well,
I won't even put you on the spot and say which one would you want to do it.
But I'm just saying, I mean, it's a preventative thing. If there have been literally hundreds and hundreds of thousands of patients that have been studied in randomized clinical trials for statin medicines, and every single trial has had a benefit in every risk group. So there is no, you hear on social media, oh, statins are bad for you, they cause this, that, and the other thing. No, statins save lives, absolutely save lives. And the maximum dose of statins save more lives than the lower doses of statins. So I can't stress enough how important it is to lower your cholesterol. It's just that simple.
What do you do when a patient says they can't tolerate a statin? And you've been through quite a few of them.
Yeah, so in the last few years, there's been some newer class of medications that are PCSK9 inhibitors that are now available, and specifically indicated for people that can't tolerate statins. And so there is an option. Now, the only downside to those is they are injectable only, so you have to give yourself a shot in your stomach, but it's every 2 to 4 weeks, so it's not like it's every day. But it's a tiny needle. You just inject it in your stomach, and it's pretty quick. It doesn't hurt really, but it's not taking a pill every day. But those are very, very effective, probably effective as statins, but they're usually a second line therapy or an additive therapy if you can't get to a goal with the statins.
Fantastic. If there are any questions, you can go ahead and unmute. Just let us know, and we'll get to your question. We do have a question coming in from Cal. What's the difference between inline flow and outline flow, and why is it important? My doctor said he got my inline flow good above my knee, but I continue to have pain a few weeks later because it turns out that I didn't have good outflow. And he said, now my only option is to walk, as there's nothing else he can do.
Yeah, that's another good question. The simplest way to understand that, inline and outline are just kind of medical terms. It's kind of like the way a river flows. You look at upstream or downstream. And so The blood has to come into the leg and it has to go out the leg. Arteries are like tree trunks. They start big and they branch into smaller and smaller ones. And by the time they get to the end, they're pretty tiny microscopic vessels that you can't even see with the naked eye. And so it's relatively easy to fix the large, big vessels, but eventually the arteries get too small as you go down the foot that the balloons and other things are simply, we don't have microscopic balloons per se. And so you can't open up the microscopic vessels, and that's where it can become a problem as well. So the blood may be getting into the leg, but it's having a hard time going anywhere. It's like a cul-de-sac in the road per se, if you think about it that way.
And one of the questions that came in before from an anonymous person was about the misconceptions in PAD care, and that there seems to be a disconnect between what's happening behind the scenes in the setting of policy and actually what patients are experiencing, in the suffering that people don't seem to understand, or the doctors or the powers that be don't seem to understand the true debilitating nature of peripheral artery disease. We've had patients that have had to retire from their jobs. We have patients that are completely depressed now because of the pain, and they just can't handle pushing through it, and it's just torture. What are your thoughts on those types of misconceptions?
Yeah, it's really due to a gross lack of education, not only of the medical community, but of the public, the lay public. There was an article published in Circulation back in 2004 where they went out and surveyed general public, just stood on a street corner or a shopping mall, wherever it was, and they asked people, what are the symptoms of PAD? And when I read it, it was astounding to what people even think of PAD is. They don't even, the lay public doesn't even know what PAD is. But when you turn on Monday Night Football in October and you see pink ribbons in the end zone, everybody knows that stands for breast cancer because of marketing and education. And so it's really just because of a gross lack of education, not only in the medical community, but like I said, in the lay community. People just don't even know what this disease is. Most people know what a heart attack is or a coronary artery disease. It's really the same disease process that occurs throughout your entire body. So you get blocked arteries in your leg, in your brain, in your kidneys, in your gut, in your heart, in your arms, all over the place. And so it's not an isolated disease to just one part like your heart. So again, it's a lot of it's misconception because there's not enough education.
And where do you think that we as kind of an industry are falling short? We've started several campaigns. We have a National Red Sock Day. We actually have a PAD Awareness Day. There's the PAD Awareness Month. It's interesting that everyone comes out for this PAD Awareness Month. The PAD Awareness Day, even though it is a national day that has been designated, hardly anyone does anything for it. We have a new campaign coming up on June 1st. It is the Light a Red Candle Day for PAD awareness and walking as the best medicine to prevent and stall progression.
Yeah.
Only one company came in, and that was Reflow. And they said, this is a great campaign to spread awareness. We're all getting involved. We're buying 100 candles for all of our employees, and we're going to go out and cross social media. And it's interesting because I attended a vascular leaders conference recently, and the university doctors, there were two of them that came out and said, oh, there's not enough awareness campaigns out there. Well, here's an awareness campaign. Why aren't you getting involved? Why are people not getting involved? Practice what you preach. We need to act.
Yeah, no, I couldn't agree with that more. I mean, that's how we're going to educate the masses. Richard Nixon said in the 1970s, we're going to cure cancer. And that was been a big push through cancer research. And so there's been a big effort. Nobody's ever come out and said, we're going to cure heart disease to the same
Which is interesting.
extent. And so PAD is an extension of heart disease, but we've never made a concerted effort as a country to try and address that problem, even though it's the number one killer in this country. And it has been the number one killer. I tell some of these patients, they come into my office and they have severe peripheral artery disease, and they're about on the verge of an amputation. And I say, your arteries are all blocked up. And they just look at me. I say, well, how would it feel if I told you have cancer? And they say, well, then, and then they start to get emotional. I said, well, you really have a form of cancer of your leg. And then they start to understand that this is a serious problem. And so all of us, like I said, no pun intended or anything, but if you've eaten at McDonald's, if you live in the United States, your chance of developing atherosclerosis, PAD, CAD, whatever you want to call it, is extremely high, extremely high. And it's a preventative disease. It starts in teenage years. We know that from kids that were killed in the Korean War and the Vietnam War, and they did autopsies on them when they're 20 years old. They have the beginnings of atherosclerosis then. But we don't typically get symptomatic until we're in our 50s and 60s. And then they say, well, I've been healthy all my life. No, this disease has been going on for 3 decades and you just don't realize it. And so there's just a gross under education for it. I think specifically with PAD, one of the reasons why it's been a problem is because there's been a lot of, to be politically correct, disagreement between the different societies that treat this problem. And what do I mean by that? You'd think that this sounds simple, but it's really not. It's much more complicated. The only people that put stents in the heart are cardiologists. And so it's a uniform discipline that everybody's been trained through the same process and through the same education, belief system, et cetera. But the people, the operators that treat PAD are cardiologists and vascular surgeons and interventional radiologists. And each of those disciplines have their own dogma, they have their own belief system, and they all think that they're the right way to do it. It's like religion. It's like arguing between Christianity and Muslim and Judaism and trying to say whose God is better, and then they start killing each other over it. And that's exactly what we face in the PAD world, is that there's discontent or disagreement among physicians about what to do with this based on their belief system. I have many, many friends that belong to other disciplines and I get along with them, but we need to cooperate more as physicians. And that doesn't happen. You have physicians that want to, for whatever reason, try and bring down other physicians. And that's a problem because it leads to these articles in the New York Times and things like that. And then patients get confused and nobody knows what's going on.
Yeah. And that's a really, really good point. And the patients have been coming to me and saying that their doctors have been bad-mouthing other doctors, other practices.
Yeah, it's terrible.
And it's a disservice to the patient because different doctors, different approaches, different tools, different techniques, equal different outcomes, but it could all be good outcomes, but it really depends on the patient's presentation of disease and their preference for the treatment, their preference for the doctor.
Yeah. I mean, it's like I said, it's a lifetime disease. We almost all of us have it to some extent. If you look at anybody over the age of 50 years old and you did a CAT scan on their aorta, they probably got some plaque in there. There's probably nobody that is free of this problem. It's just some people develop it a little more aggressively and are a little more symptomatic. But treating it with the underlying medications, like I said, aspirin, anticoagulants, blood pressure medicine, cholesterol medicine, diabetes medicine, even stopping smoking is critically important. A lot of people don't, I can't tell you how many people come to me and they smoke and I say, well, you got to stop smoking. They just laugh. I said, no, it's like you're hitting your thumb with a hammer and you want me to make your thumb feel better. You have to be accountable. People that smoke cigarettes, within 60 seconds of smoking one cigarette, your body releases blood clotting proteins like fibrinogen, which in layman's terms basically makes your blood start to thicken like Jell-O. That effect can last for 12 hours with one cigarette. And so when I put a stent in and we spend several $1,000s on that as a healthcare system, and you continue to smoke, it's a problem. And then you come back and your stent's all blocked up and you want me to fix it again. And so there has to be some accountability as well. So this is a complex cycle. It's a complex situation. It's just, I think we just need a lot more education through the medical community, of the people that are being trained, and of the public, so they understand what the process is.
Here at the new Cardiovascular Horizons conference in New Orleans, Louisiana, world-renowned researcher for PAD, Mary Yost, talked about a very disturbing trend that PAD is becoming prevalent in a younger and younger audience. And in fact, there was an article that was published in Science Direct talking about the rising number of critical limb ischemia patients between the ages of 18 and 24, not presenting until the point where they need hospitalization and advanced treatment and possibly even amputation. These patients are in their 20s.
Yeah, I mean, there's a rising problem in this country with things like obesity, diabetes, hypertension. Um, uh, that leads to chronic kidney disease, which is also a problem. Um, a lot of the teenagers have stopped or gotten away, per se, from, say, cigarette smoking than the older generation had at that age point. But then now they do vaping, which is just equally as bad. And so there again, it's just a lack of understanding. When you go out to a shopping mall, I mean, I live in Iowa. I mean, you go out to the shopping mall and you look at the people that walk around, 50% of them are massively obese.
Mhm.
They're massively obese and they come in and they want me to fix them. I'm like, I can't fix that. You have to help me fix that. I can unclog your arteries, but there's an underlying disease process that needs to be addressed as well. And it's hard to tell people you need to lose 150 pounds. And they just look at you. And so it's this is where the disease comes from. And so the earlier those risk factors are developing, the earlier the disease process is going to start.
Yep. Here at the conference, lots of talk about advances in medicine. One in particular was a bioabsorbable stent to be used below the knee. There's also what used to be known as the PQ bypass. It was actually purchased by Endologix. It's now called PTAB or Detour. And their booth is sitting right across from us right now. What advances in medicine are really catching your eye and you're most excited about?
Yeah, I think that, we certainly have not solved the problem. There are patients that, despite what we do, they have aggressive disease or the arteries continue to block up. So new advances like PQ bypass, for example, is an option for patients that have severe blockages or are unable to be treated conventionally with a stent. There are some limitations in who it applies to. But there are techniques like that are being developed without, getting into a whole lot of the details that confuse people. But there are options because even in the best circumstance, even if I have a perfect outcome and someone that has CLI, the chance of limb salvage is 90+%. There's still 10% of the people are going to lose their leg. So we haven't got to that 100% cure per se, that number yet. So there's people that are always kind of working on making things better and new devices, new technologies, things like that.
There's a lot of resistance in some practices that they don't want to treat below the knee. They still don't think it's worth it. They still rely upon 2013 data that says it's not worth it to treat below the knee. You're only going to increase the chance of amputation. But a lot of new technologies are coming out. Do you think that we're going to see a change of heart sooner rather than later with this philosophy?
Yeah, I do. I think that the tibial world specifically that you're talking about, or the arteries in the calf, is for the PAD world kind of the last frontier, and it's probably conservatively 10+ years behind the rest of the technology we use anywhere else. There's a lot of reasons for that through history and stuff, but I do think there's now companies that are starting to focus on that area. Tibial arteries, the calf arteries are difficult because they're relatively long and they're a relatively small diameter.
Mhm.
So they go from roughly your knee to your ankle, but they may only be an eighth of an inch or less, a quarter of an inch in diameter, whereas the arteries in your thigh or above that are significantly larger in diameter. And so as you get down into smaller and smaller arteries, it takes less and less plaque, if you will, to re-occlude those. And so they don't like to stay open very long. Plus, the disease process in the tibial arteries is a little bit different. It's probably has a little more calcium in it, which is harder to treat sometimes. But I do think that companies are starting to focus on that area a little bit more. And we're starting to see now a number of companies that have new devices that are coming out or in clinical trials that will be hopefully available in the next couple of years.
Yeah, cool.
One of the frustrations from my standpoint has always been, and this is as long as I practice medicine, is our FDA approval process is excruciatingly slow. And they have reasons for that, but it's the government bureaucracy. And you could look at something today and say this is great, but it's still maybe 5-10 years before it reaches the market. And so there's quite a delay in a lot of these things, but there is a lot of work going on in that arena.
And I have one more question for you, just in because it's almost like the elephant in the room here. I even heard Dr. Marco Bonzi being asked the question. He was doing a live case here. He's broadcasting live from Italy to our conference here in New Orleans, Louisiana. And someone on the panel of doctors asked him, "Well, how often do you use atherectomy? What are your indications for using atherectomy?" Because it is such a point of contention here in the United States, when to use it, when not. We have a Dr. Caitlin Hicks who came out with a study several years ago that said that atherectomy increases the chance of amputation. But then we heard from Dr. Jihad Mustafa during this conference, who has data that proves otherwise. How do you as a patient sort out this data and know what to believe? Because it seems as though even doctors cherry pick which data they want to believe, which one supports their agenda and their philosophy versus kind of looking at the big picture. And so it's very confusing for patients. They bring me these studies all the time. They're like,
Yeah.
which one do I believe?
Yeah. That's gets back to the point that I was trying to make with the disconnect between the different disciplines and different societies and vascular medicine. And that's where we as physicians do a disservice to patients when we argue and disagree about things. It is confusing at best sometimes. Unfortunately, there are relatively few people that actually are dedicated to treating CLI patients. And I think when you look at the numbers, just in cardiology, for example, there's probably 50,000 cardiologists in the United States. Less than 10% of those actually do PAD work, and less than 2% of those actually are dedicated CLI operators or critical limb ischemia operators. So you have an underpowered, an underpowered workforce to try and deal with this problem. And so many of the people that present these opinions simply don't do these procedures at a high enough volume or even have an adequate amount of experience to even understand what they're talking about. And so you do have to be careful sometimes in who you listen to. The best analogy I can describe is what we went through with COVID, when there was a lot of misperceptions about treatments that were coming out that were on social media and things, and patients get desperate and they start to go to Google and other things like that, WebMD, to try and get answers. I would encourage patients to seek out physicians that do a high volume of cases and are very well experienced and versed in the discipline of PAD, and not simply academic physicians that don't have the experience per se. There's a lot of articles that get published out there. And if you're not a doctor or medical professional that's versed in biostatistics and understand how to read them, a lot of them are crap, and I'll just leave it at that.
Yeah, and it's interesting. One of the things that at this conference, it was during the fellows track where they were training some of the next generation of limb salvage specialists here at this event in New Orleans, Louisiana, the NCBH. And it was all about the dangers of being a doctor and treating PAD, the dangers of the radiation. And what I find, and the way I look at it, is some of the doctors that don't want to go to the extent that you all do are arguing for their own limitations, because it is dangerous. You're literally, the time that you spend for each and every patient to literally patiently eke your way through some of the most complex lesions, just praying that you're going to get them that much more blood flow to keep their leg. You're putting your life on the line every single day for these patients. These so-called CLI fighters truly are heroes in putting their life on the line, because you're sometimes exposing yourself 3 to 4 hours per patient per day to that radiation.
Yeah, it's something that goes through my mind. But I'm passionate about what I do, and I try not to think about it in those terms. And I figure that I'm going to die of something someday, and I'm going to put my time in as much as I can while I'm here to help people out. And when it's your time to go, it's your time to go. But I feel that we've all been put here to do something And if you don't do what you're put here to do, then you're wasting an opportunity that somebody else didn't have. So that's kind of the way I look at it.
I love it. True words spoken by a real CLI fighter.
But no, there's no question. It's definitely there's not enough people in the workforce to do what we do.
No.
There's a lot more need than there is, and there's a lot more education that we need to do.
Thank you so much, Dr.
Yep.
Eric Dippel. We really appreciate you.
Yep.
He's in Des Moines, Iowa. If anyone's